Good morning, everybody. Happy July and welcome to this edition of our webinar series. I'm Dr. Chantal Witten. I'm the Director, Health System Strengthening at ILIFA, and I will be facilitating this session today. The Early Childhood Systems, Perspectives and Research webinar series is a joint initiative of ILIFA Labantwana, Research on Socioeconomic Policy, RESEF, which is in the Department of Economics at the University of Stellenbosch, and Data Drive 2030. The aim of the webinar series is to explore the latest perspectives and research on a range of issues affecting the early childhood development service delivery ecosystem, and to create a change for children through the use of data and research. So a few housekeeping guidance. Please put your questions as the presentation is taking place. Please put your questions in the Q&A. You may also raise your hand if you have a question, but I will only entertain if we have time for people to ask their own questions. Otherwise, post your questions in the Q&A. If you have comments, we have our technical team that are also following in the chat, and we'll be taking those at the end of the presentation. So it gives me great pleasure to introduce today's topic. The topic is vaccine coverage and timeliness among children of adolescent mothers, a community-based study in the Eastern Cape, South Africa. May I take the opportunity to introduce our presenter today? Camille Wittesaele is an adolescent and child health researcher at the London School of Hygiene and Tropical Medicine. Her work has focused on conducting impact-driven maternal, adolescent, and child health services research. Since 2014, Camille has worked in the design, development, and implementation of several observational cohort studies with the distinct aim of informing the design and delivery of services for adolescents and their infants and children. She has extensive field work experience in rural and urban settings in 3 South African provinces. Camille's PhD, which she's proud to have submitted recently, examines engagement in the World Health Organization recommended wild care visits among children of adolescent mothers in South Africa. Camille is the co-investigator for the Hey Baby study and an early career researcher at the Accelerate Research Hub. Her research interests include maternal, newborn, child and adolescent health, child health outcomes, sexual reproductive health, wild care services, health services research, childhood vaccine, and HIV. I am now going to hand over to Camille and invite her to put up her slides, and she will have the next 30 to 35 minutes for presentation. Over to you, Camille.
Wonderful. Thank you, Chantal, for that introduction, and I'm delighted to be presenting today. So today I'll be sharing some findings from some mixed methods research that we've done on engagement with well care services amongst children of adolescent mothers in the Eastern Cape. And just before I get started, I just wanted to say that the research that I'll be presenting today has relied on a major data collection effort in collaboration with the University of Cape Town, Oxford, and my research has been based at the London School of Hygiene and Tropical Medicine. And just to acknowledge as well my co-authors and colleagues on this research. So just to start off with a brief outline of today's presentation. So I'll give a brief background on how well care services link to the early childhood development ecosystem in South Africa. And the rationale for exploring well care visits engagement amongst children of adolescent mothers. Then I'll briefly touch on the methods of the study, but I will keep this quite light. So if there's any questions at the end of the presentation, I'll be happy to answer any questions about the methods more specifically. Then I'm going to try and cover 3 findings from 3 studies. The first is looking at vaccination coverage, timeliness, and well care visit attendance patterns. The second study is presenting research, qualitative research, exploring what influences attendance amongst children of adolescent mothers. And then I'll also be presenting findings from a quantitative study which explored factors associated with retention in the well care visit schedule. And then we'll move on to a discussion where we'll reflect on some of the implications of these findings for programming and policy. So just to dive into the background. So we're all here because we're very motivated to support early childhood development. But I just want to highlight that it's not only important for improving health and well-being for individual children, but it also has the potential to impact health and well-being across the life course and interrupt transmission of disadvantage across generations. In low and middle income countries, 250 million children under the age of 5 are found to be at risk of not reaching their developmental potential. And early childhood development, ECD programming aligns with the global shift in focus from child survival, which has been focused really on ending preventable deaths, and shifting our attention to thriving to ensure child not only health, but also well-being. So in South Africa, WellCare visits are a key contact point to deliver early childhood development programming. In South Africa, the Side by Side campaign was launched to support child survival and thriving. And this is an initiative that promotes nurturing care and encourages collaboration between caregivers, healthcare providers to ensure that children receive the nurturing care they need to survive and thrive. This campaign is centered around 5 pillars, which I've highlighted here. And alongside other platforms such as ECD centers, WellCare visits operationalize the delivery of these 5 pillars. These visits also provide one of the earliest opportunities to deliver ECD starting from birth and are often the first contact point between children and caregivers with the healthcare system. So the WHO has recently released guidance on the schedule of WellCare visits, outlining the timing and frequency, as well as the content of what interventions should be delivered during these visits. And this guidance it covers for children and adolescents from birth through to 18 years old. It includes recommendations for developmentally appropriate health promotion and preventive care, and it defines WellCare visits as routine and regular checkups by healthcare providers to ensure the healthy growth and development and well-being of children in the first 2 decades of life. So how does this look in South Africa? So in line with the WHO guidance, children in South Africa are expected to attend these routine visits at recommended intervals. I've just sort of summarized the schematic here of the most intensive part of the WellCare visit schedule for children in South Africa. So that's from around 3 to 6 days old until the 18 months. And as you can see from the schematic, at each different visit, there's different recommendations for different preventive and health promotion interventions that healthcare providers should deliver to children who are attending these visits. So these services really focus on the prevention, early detection, and management of potential health issues. And they're really crucial for monitoring the healthy growth and development at age-appropriate stages of a child's development. There are also opportunities to support parents and identify issues to link children to social services or any specialist services that they might need. Healthcare workers then document data in patient-held child health cards, which we call Road to Health booklets in South Africa. And I'll also just say that, as I mentioned, WellCare visits are really supposed to be from birth through to 18 months. And this is why at a later stage, when children become adolescents, school health teams will reach adolescents through the integrated school health program in South Africa, where the adolescents will receive health screening, disability screening, additional vaccinations such as the HPV vaccine, any mental health screenings as well. And these are delivered at schools through school health teams. For this presentation today, I'll only be covering WellCare visits for children, but the reason why I highlight that WellCare actually extends through to the adolescent period is because we're focusing on children of adolescent mothers, and therefore we're thinking about the dyad of both the adolescent's needs as well as their child's. So what is the rationale for this study and for looking at children who are born to adolescent mothers? Well, a lot of research has shown that children who are born to younger mothers experience worse outcomes. In South Africa, 16% of adolescent girls, 15 to 19, had either given birth or were currently pregnant at the last DHS in 2016. And this is predicated by multiple factors, including low access to health services amongst adolescents and sexual risk behaviors, which are inherent to the adolescent developmental life stage. Adolescent pregnancy is associated with malnutrition and stigma, as well as increased financial hardship amongst adolescent girls, and increases the odds of delayed schooling. There's been an increasing amount of attention on the children who are born to these adolescent mothers who experience worse birth outcomes. So there's recent data that has been shown that children who are born to these young moms are at higher risk of anthropometric failure. So they're more likely to be born, for example, small for gestational age, experience undernutrition, experience earlier breastfeeding cessation, have delayed cognitive development. And in South Africa, some studies have also shown that they're more likely to experience delayed access to the child support grant, which we know is really important for food security, but also in order to provide resources to be able to access health services. For children with perinatal HIV exposure, those who are born to adolescent mothers living with HIV are at 3 times higher risk of vertical transmission compared to the children who are born to older mothers who are living with HIV. And they have lower access to the early infant HIV testing and increased risk of negative outcomes from vaccine preventable diseases as well, due to lower immune protection at birth. So this is just to highlight that well care visits and these contact points are an incredible opportunity to address some of these risk factors amongst children who are born to adolescent mothers. So in this study, the aim was to examine utilization of these well care services amongst children of adolescent mothers in the Eastern Cape. And we completed 3 studies. The first was to investigate vaccination coverage and timeliness, and we compared that by maternal HIV status. And the purpose of this study was really just to get an early insight into what coverage might be of well care services overall, and we use vaccines as a proxy for that. The second study used mixed methods to explore what factors influence attendance amongst adolescent girls and their children. And then the third study examined factors associated with retention in the well care visit schedule. So just briefly on the methods, today I'll be I'll be sharing data from a large cohort of adolescent mothers and their children who are living in peri-urban and rural health district in the Eastern Cape of South Africa. Using data from a study called Hey Baby, which aims to identify resilience promoting pathways for adolescent parent families. So this cohort study is linked to a larger adolescent antiretroviral adherence study, which carried on over 3 waves from 2014 to 2019. And between 2017 and 19, we did an additional recruitment drive where we invited all the adolescent girls in that study who had become mothers into the Hey Baby study. And we did an additional recruitment drive as well to ensure that we had a large enough sample size. And we used both community-based and clinic-based sampling to ensure that the cohort was representative of both adolescent girls and their kids who with and without existing access to health services. Just to highlight that at baseline, we did adolescent parent surveys where the adolescent mother answered questions in an electronic survey. We took photos of Road to Health booklets, and we also did child cognitive development and motor skills assessments. At follow-up during COVID, we did qualitative interviews remotely via telephone, and currently the final round of data collection is underway, where we're doing a follow-up of all the baseline research instruments. In this study, I'll be mainly using data that's taken from photographs of all the Road to Health booklets that were available for the children. So around 94% of the children had Road to Health booklets available at baseline. And we're using data from the WellCare visit page and the vaccination page to measure vaccination coverage and attendance to the WellCare visits. And we're also using data from the surveys with adolescent mothers for sociodemographic and health access data. During COVID, as I mentioned, we also did semi-structured interviews with adolescent mothers who were purposefully sampled from this cohort. And we mainly aim to include moms in qualitative interviews who had recent or current experience attending WellCare visits. So moving into the findings, the first study, as I mentioned, looked at vaccination coverage and timeliness. Just briefly, we looked at 3 different indicators of vaccination coverage. So the first is the DTP3 coverage, which is a 3-dose vaccination for diphtheria, pertussis, and tetanus. And that's given at 6, 10, and 14 weeks. We also looked at under 1 vaccination coverage and measles second dose coverage, as well as timeliness of vaccination uptake. So just to highlight here, these are the 3 different vaccination coverage indicators. 86% of the children who were over 12 months old in our sample had the 3 doses of the DTP vaccine. And then for the under 1 vaccination, for the under 1 coverage indicator, around 60% of kids had under 1 vaccination coverage, and around 62% had received the second dose of the measles vaccine. So here we can see that the vaccination coverage was highest for the vaccines that are earlier in the vaccination schedule, but then it declines as we included vaccines that were that are administered later on when children get a little bit older. Other than the DTP3 vaccination target, children in this cohort did not reach the national vaccination targets. And when we compared children of adolescent mothers who were living with HIV versus children who were born to mothers who were HIV negative, we found that children had a lower vaccination coverage amongst those who were born to adolescent mothers who were living with HIV. Just to say that we might want to take away from this that WellCare visit attendance is really low. But we found that whilst looking into this data, that perhaps vaccination coverage may not be the most reliable indicator to reflect attendance to WellCare visits due to high levels of stockouts and missed opportunities for vaccinations, where, for example, a child might attend a healthcare facility but not receive a vaccine, and therefore it might look like they didn't receive a service even though they did attend a facility. Then we also looked at vaccination timeliness just to get a sense of perhaps gaps in immune protection as children go older, but also perhaps to get a more granular insight into attendance patterns. So here we see for the earlier vaccines it's relatively high and good timeliness, but the timeliness declines as the vaccination schedule progresses. And this highlights gaps in timely uptake of not only vaccines, but also contact with child health services. When we compared timeliness by maternal HIV status, we did not find any evidence of a difference. And again, we see the similar pattern of this declining timeliness and coverage with child age. So as I mentioned, vaccination coverage might not be the best proxy for attendance due to stockouts, which were reported during the study period. So we also looked at WellCare visit attendance using data from the WellCare visit page in the Road to Health booklet. And this is just a graph that's showing the proportion of kids who had a record of attending a WellCare visit in the WellCare visit page. The first thing to highlight is that we had incredibly low attendance during the neonatal period from 2 to 31 days old. The highest attendance was at the 1-month visit, with around 89% of children having a recorded visit, but then this declined to around 40% of kids attending WellCare visits by 18 months old. We see these spikes, which align with the vaccination schedule. So this is perhaps nurses who are recommending that children maybe only attend during visits that coincide with the vaccination schedule. So then we wanted to qualitatively explore what influences well-care visit attendance amongst adolescent girls and their children. So we did 16 semi-structured interviews, and the interview guide tried to explore constructs related to the capability, opportunity, and motivation model of health behavior. And these were analyzed using the same framework. Using this theory-informed approach, we developed many themes using the qualitative data, which align with the different domains in the framework. And I'm just going to highlight some of them in this presentation. So the first and most dominant theme is really that adolescent mothers found well-care services really important, in particular childhood immunizations. I'll just highlight this quote here, where a mum said it's difficult because you dread the distance, but you understand that it's necessary. And here's another mum who's saying that sometimes she felt like she was not in the mood, but she had no choice because she is a mother and she has to take her child. And here, even sort of highlighting that she's foregoing a job opportunity in order to take her child to the health facility. However, this kind of contradicted a little bit with this decline in vaccination uptake that we saw, as well as attendance in the well-care visits schedule. So we identified as well in the qualitative interviews that there might be a decline in the perceived benefit of these well-care visits as the schedule progresses. And here's one quote from a mom who says, "I don't miss my visit until my child reaches 1." I'll also highlight that adolescent mothers might have been motivated to portray that they wanted to attend these visits as a way to demonstrate good mothering. And they also use this opportunity to learn, use these well-care visits as an opportunity to learn and obtain reassurance about their child's health. Here's one mom who said, "I learned a lot by taking my child for immunization because it's then explained to the parents in a way that she must breastfeed the child and things about prep and condom use. You learn a lot." And here's another mom who says, "You learn about the do's and don'ts when you have a child." So it's a really appreciated opportunity for the moms to address a knowledge gap that they might feel that they have during, after giving birth for taking care of their child. What was encouraging was that adolescent moms were highly capable and of attending these visits. They had the intention to want to comply with the schedule. They understood that the nurses wrote in their Road to Health booklets when their next date was, and they leveraged their organization and financial acumen in order to try and make sure that their child was as compliant with the schedule as possible. What was quite interesting, particularly in the context of adolescent girls who may have historic negative experiences with the healthcare system, is that they demonstrated an indifference and even tolerance towards harsh attitudes from healthcare workers. So here's one quote demonstrating this. There's a mother we spoke to who said, "Yes, they shout, but I have that thing that says there's a reason they shout. They would never just shout at you. They have the right. They're helping your life at the end. Without knowing them, I love them. Or maybe it's just because I'm used to it." And then finally, in the opportunity domain of the framework, we identified several barriers and facilitators for well-care visit attendance. These barriers are quite known in South Africa, including distance and cost of transport. But weather was an important consideration, especially for adolescent mothers who were now having to go to the clinic whilst carrying a child and carrying clothes and toys and food for their child for long waiting times at the clinic. They highlighted unsuitable waiting areas for their children, in particular during COVID-19 when they had to be waiting outside the clinic. Things that facilitated attendance, however, was the Road to Health booklet. So adolescent mothers spoke about the Road to Health booklet being a really important tool to help them track when the next visit would be and when they're expected to attend. I'll just highlight here one quote about a mom describing that Road to Health booklet where she said, "It opens your mind with regards to the baby because you don't know anything about the baby." Other factors that facilitated attendance is a large social support network. So adolescent girls were able to call on grandmothers and aunts or a child's father to provide transport money or even to take children to the welfare visit to the primary care facilities. So the implications of some of these findings are that, first of all, it's really encouraging to identify that there's an existing scaffolding to promote attendance, with mothers being both capable and motivated to attend. And there's a large availability of caregiving support that the children have access to in order to attend these services. However, we do see this declining importance over time and this pattern of declining attendance over time in the quantitative data, which needed to be further explored. These qualitative interviews, I'll just highlight, identified factors that influence attendance, but not retention in the well-care visit schedule, which brings me to the next study. So this final study explored factors associated with retention. What we did is, instead of looking at attendance to all of the visits up to 18 months, we identified 8 WHO-aligned well-care visits. And looked specifically at just these children who are attending all of these WHO-aligned visits through to the 18-month mark. The reason why we're interested in looking at retention all the way through to 18 months is that this is an important milestone for assessing the child's overall health and development before visits become less frequent. And therefore, it's a crucial window for detecting and addressing any developmental delays, also because some developmental and childhood development challenges can only be screened once children reach this age. It's also the last point where the children receive their last childhood vaccination schedule. So it's the last opportunity to be able to make sure children are caught up on any missed or delayed vaccines. And it is for the prevention of mother-to-child transmission program, the exit point of that program, and it's where children are supposed to receive their final confirmatory HIV test. So we looked at several measures of retention before going into the quantitative analyses. The first is we looked at how many kids actually attended all of these 8 visits within 4 weeks of the recommended age. And we found that in our cohort, amongst children who were 19 months or older, around 20% of kids attended all of these 8 visits. We then also looked at children who might have missed only one visit, the last visit, and we found that 40% of kids attended all but the last visit. So this kind of, again, reflects this pattern of declining attendance that we saw in the Road to Health data. For the study, we came up with a measure called optimal retention, and this was defined as children who had not missed more than one visit, but completed the schedule. And the reason for this is that children who might have missed a visit at some point during this schedule and who return at a subsequent visit should, in theory, be receiving any catch-up health promotion messaging or preventive interventions from healthcare workers. So really, it's most important that children are staying quite consistent, but attending visits all the way through for these well-care visits to work effectively. So using the qualitative interviews, we developed a conceptual hierarchical framework for analysis. And this supported a multivariable logistic regression using a hierarchical modeling approach. And we use this to examine factors that are associated with optimal retention, as defined earlier. So first, we put in socio-demographic characteristics in the model, and we identified that children who were living in rural areas and whose mothers had reached secondary school education at the time of the child's birth were more likely to have optimal retention in the well-care visit schedule. And this is after adjusting for birth year, the maternal age at birth, mother's HIV status, and food security, which we use as a proxy for household income. Then we added mother's health behaviors to the model. And it was really interesting to see that children who were born via cesarean were more likely to stay retained in the well-care visit all the way through to 18 months. And I'll discuss this in a moment. Then we added support factors to the model, and we identified that none of these factors seem to be associated with retention in the WellCare visit schedule. So that included adolescent girls who received caregiving support, children who were cohabiting with their mother, access to the child support grant, and mothers returning to school after birth. We then also looked at health service factors that may be associated with retention and identified that longer distance to the clinic was negatively associated with the outcome. I'll just highlight here in gray that these factors were there were some marginal associations with the outcome. So here we see that children whose mothers were living with HIV had marginal but slightly higher risk of not being retained in the schedule, and that food security was marginally protective. And I'll also just highlight here that access to the child support grant was also marginally protective. So what are the implications of these findings? So first, I'd like to just highlight that universal interventions may be needed to promote retention beyond the neonatal period. The reason why I'm talking about universal interventions is that we tend to focus on at-risk children, for example, children who are exposed to HIV through their mothers living with HIV. But we need to perhaps look at children of adolescent mothers more holistically so that we don't miss out on this high-risk group. We need to address structural barriers to access, such as distance to healthcare facilities, and we're missing opportunities for referrals to occupational speech and physical therapy because children are not attending healthcare visits at a time where we can actually screen for developmental delays. It's interesting that we identify the protective effect of cesarean birth beyond the postpartum period. So it may be logical to see higher attendance in the postpartum period amongst children who had a cesarean birth because mothers may be more motivated to attend primary care for their own follow-up care, for having their stitches looked at, for example. But it's interesting to highlight that we saw this protective effect all the way through to 18 months. And so this needs to be explored further, but some hypotheses that we have around this might be that there may be something protective going on where mothers who experience a cesarean birth may have had more attentive care from healthcare providers while they were at the birth facility and may have had more intensive interactions with nurses and received more directed care towards them, which may have helped them be more motivated to attend healthcare services beyond that postpartum period. The better retention that we identified in rural areas may be due to rural-friendly models of healthcare delivery, such as mobile clinics and community health worker outreach as well. So some reflections on the implications for practice and programming. So just to highlight, again, some of the main findings from this research overall is that children have suboptimal attendance and there may be a decline in the perceived importance of visits over time. And therefore, we've identified a missed opportunity for delivering ECD interventions and for the early identification of health and developmental issues. And therefore, we're missing out on opportunities to refer children to specialists and social services. Secondary to this is also, although we're focusing on children of adolescent mothers in this study, we are also seeing that this is a missed opportunity to provide care to adolescent girls who may no longer be accessing schools and therefore not have access to the school-based outreach of health services. We identified that adolescent mothers may have specific unique experience which differ compared to older caregivers. For example, mother's motivation to attend these services may be rooted in the sense of maternal obligation or a desire to demonstrate good mothering, which adolescent girls may be more incentivized to do to counter the stigma of adolescent motherhood. They may experience unique psychosocial drivers for healthcare utilization compared to older caregivers, and they may be able to leverage more kinship support compared to um, older caregivers with the availability of grandmothers or also aunts of the children. Um, while mothers in the qualitative interviews portrayed being really motivated and capable of attending these services, they were hindered by structural and health service barriers. So children in urban settings appear to have face higher barriers to staying retained in the well care visit schedule. And distance to the clinic was also identified as an important barrier. So is there some messaging for programming and practice? I'd like to highlight that as much as we have a tendency to focus on children in these well care visits, when adolescent mothers are going with them, we need to see them as a shared dyad, both with well care needs and each facing their unique circumstances. So on the child side, children of adolescent mothers are both accompanied sometimes by their adolescent mother, but also other caregivers. And this has implications for programming in terms of disseminating information to different types of caregivers, such as grandmothers, aunts, or the adolescent mothers themselves. On the side of the adolescent mother, healthcare providers should be cognizant that these adolescent girls are both caregivers, but they're also adolescent girls with their own unique health needs. So in order to perhaps enhance the quality of well care services, we found relatively high coverage of these services, but perhaps there is scope for improving the quality of the delivery. It'd be helpful to improve the interaction between healthcare workers and adolescent mothers, which may incentivize adolescent mothers to attend more because they're receiving more attention during these well care visits. Well care services should be age and developmentally appropriate at each visit. So I didn't really cover this in detail when I was presenting the qualitative findings, but adolescent mothers really seem to be to define these visits as contact points merely for vaccinations and for growth monitoring. However, these contact points are incredible opportunities to provide parenting support, to provide nutrition support, and a myriad of other health promotion and preventive interventions. And these should align with the child's health and development and change as the child and evolve as the child ages. Addressing vaccine stockouts and missed opportunities for vaccination would also motivate mothers to attend visits more because then they're receiving more complete and comprehensive, high quality health services. Reducing waiting times, perhaps by allowing adolescent girls to be prioritized in queues, may also be helpful in incentivizing their attendance to these well care visits. As we all know, in South Africa, there's issues with barriers to access. It's interesting to highlight that in rural areas, children seem to have better retention in the well care visit schedule. And therefore, exploring community facility linkage models such as community health workers and mentor-mother models may bring children and adolescent mothers closer to healthcare providers. I'd also like to highlight that we should perhaps explore how we could leverage this opportunity to reach adolescent girls as well. First, by enhancing the perceived benefit of these well care visits for themselves as mothers and as adolescent girls, not merely having these visits be of benefit to the children, but also themselves as a mother and a young woman. We'd recommend universal person-centered interactions, which are both HIV and age responsive. This includes providing age responsive and HIV responsive parenting advice, psychological support. On the aspect of adolescent girls, we could also provide linked health services such as physical examinations, HPV vaccinations, and depression screening, and continue bolstering the delivery of integrated sex reproductive health services such as family planning and STI testing. In terms of the side-by-side campaign, we could perhaps use Mom Connect as an avenue to increase knowledge about well care visits to the adolescent girls and emphasize the importance of ongoing attendance. So such messaging could highlight to adolescent mothers and all mothers actually that ongoing attendance is important for the child's to monitor the child's development as their child is growing older. It'd also recommend that adolescent mothers be involved in the next revision of the Road to Health booklet, just to ensure that there's information in there that may be more tailored to their needs. We could then also leverage the Nurse Connect SMS service to highlight to nurses that these visits are not just opportunities to address nutrition, immunization, and growth monitoring, but that these are essential contact points with mothers for all 5 pillars of ECD, including love and extra care. So this is an opportunity to provide parenting advice and support, perhaps also explore whether any linkages to social services may be needed. Nurses should also highlight to the adolescent girls that ongoing attendance is necessary for monitoring the healthy growth and development of their child over time, not only when their child is younger. And then finally, I would just like to highlight just some evidence gaps that remain from this research. As I highlighted during the presentation, we identified that attendance during the postpartum period is very low. So we need to carry out additional research to identify strategies to promote attendance during this high-risk period. It may be worthwhile to carry out an evaluation of the well care visit schedule in terms of what frequency of visits is necessary, how important timeliness actually is. We also found that during this research that adolescent mothers relied quite heavily on elderly and other caregivers, and elderly caregivers may face additional barriers to accessing primary care facilities, such as their own mobility issues or their own health being potential barriers. So it should be explored how we can include them in making sure that children are involved and attending ECD and receiving all the full ECD package. And then finally, as much as the focus of this presentation has really been on the utilization and attendance to these services, I would recommend that that there's definitely scope for evaluating the quality and comprehensive delivery of these welfare visits to see how well they're adhering to the WHO guidance and what more could be used to bolster this opportunity, because caregivers do seem very motivated to attend these services. Okay, and I think that's all for me. I just wanted to thank all the participants who participated in this research, and the amazing data collection team and my supervisory team who supported this research, as well as our partners and our funders in the study.
Thank you so much, Camille, for that presentation. We have a couple of questions. I'm going to read a set of questions that has been put forward by Sibongile Kumalo. So Sibongile says, Wildcare visit attendance, what are your thoughts on how we can get these happening in the neonatal period? And I want to add to that neonatal period and the relationship with the C-section as a whether that was looked in sync, right? And then the second question is, can we legally incentivize visits with distribution of childcare grants or in any other ways? And then a last question, do children really ever catch up to their vaccines outside of the 4-week window for each age? And is this then recognized, or is it counted once they've caught up? So do you count it only once they've caught up on their vaccinations, especially for your indicator of fully immunized by 12 months? And then just a question also about attendance to the clinic, because in the research design, you use the Road to Health booklet as a record of attendance. But is that attendance by the adolescent mother herself? Is that attendance by another caregiver? And yeah, I think those are quite a mouthful already. So I'll give you some time to respond.
Great, thank you. I hope I'll cover those comprehensively. So we really have not looked at the neonatal period in any detail, and I also did not explore cesarean section, whether children who were born by a cesarean section were more likely to attend in the neonatal period. Um, and therefore, I can't really comment necessarily on strategies. I did try to look into this, but there is I would say definitely scope for exploring this more. Um, there's different considerations to this because on the one hand, one might assume that having had an operation might incentivize you to attend healthcare facilities for your own care and for your own checkups. But at the same time, having had a surgery and needing to recover from that might actually be a barrier for attending well-care visits during that neonatal period. So it definitely needs to be explored in more detail how that can be supported. Um, in terms of the legal avenues to provide the child support grant to children at welfare visits, I'm unable to comment on that really. What I do know is that in South Africa, in order to attend to receive a birth certificate, you need to have the Road to Health booklet in order to have that. And therefore, and that is what is necessary for you to be able to access the child support grant. I'm not sure. I think it would be incredibly valuable for that to be accessed and linked up at the health facility, but I can't really comment on how that might be operationalized. In terms of the delayed vaccination, not necessarily meaning a missed vaccination. So in our study, the vaccination coverage is indicator is looking at, for example, for the under one vaccination coverage, we looked at everyone who was over 12 months old and looked at how many of those kids had received any of the under one vaccines by 12 months old. So this includes people who received it late, but did receive it eventually. And this is why timeliness data is actually very telling, is that we can have pretty high vaccination coverage by the time a child reaches 18 months or even 2 years, because they do eventually catch up. But the problem is that they're actually getting these vaccines delayed. And this is a concern, particularly because children are at risk of these vaccine preventable diseases during that younger period where they're not fully protected. And then the last question about attendance and whether we know that the adolescent mother was always going with the child. We don't know this. The study really was focusing on children of adolescent mothers, and there was no way to tell from the Road to Health data who was attending the child with, who was going to the clinic with a child for these well-care visits. And this is why the qualitative interviews were very insightful, because what I took away from that is that children are supported by many people, including the adolescent mother. At first, at the outset of this research, after being in the Eastern Cape for several years, I had almost assumed that children were mainly going with the grandmother to these health facilities, when actually a lot of the adolescent mothers we spoke to had firsthand experience of what they experienced welfare visits being like, and they prefer to go themselves. And it's only when they cannot do because of school or because of work that they might rely on another caregiver to take the child for them, take the child to the welfare visit for them.
Thanks, thanks, Camille. That's very encouraging. I think the fact that young people, or not young people, young mothers take responsibility and are experiencing the care of their children is very encouraging. The question I would like to ask, because we see this decrease in attendance with age, was there in the research a question about what are the care arrangements for these young children? The assumption is that they may be going into ECD programs, they might be going into ECD facilities. Do we have an understanding of what's happening over the time after 12 months?
This needs to be explored more, and I can potentially link you with some colleagues who are looking specifically at ECD access and attendance, but it seems to start a little bit later, which is why well care visits are such an important opportunity, such an important period for ECD before children start attending ECD centers.
Okay. We still have a few minutes. If I don't see any other questions, please, I'd like to encourage you to post your questions in the Q&A section. I'm going to pose two questions. The first one is around the support of adolescent mothers. Do we have an understanding of what are kind of the support structures that they may have? I do find it very interesting that they say it is, the well baby visits or the baby clinics is an opportunity for information and knowledge. When we know from other research that actually the nurses don't have enough time to talk to mothers. So my question is, who's engaging in providing that knowledge? Is it a peer support, when everybody's coming together, or are they accessing that information somewhere else? Yeah.
Yeah.
Any
It's
ideas?
interesting. In the qualitative interviews, the adolescent mother really spoke about the nurses telling them about the breastfeeding, how they take care of their child. Um, and this really was in the first few visits. I think once those first few visits have passed and the mother is kind of getting used to how to take care of her child, there's less sort of intense interaction between the nurse and the adolescent mom, is what we heard from the adolescent girls that we spoke to. The other resource that these adolescent mothers that we spoke to in the qualitative interviews really highlighted that the Road to Health booklet, that the nurses would highlight to them the importance of the Road to Health booklet. Make sure you never attend a clinic without it. Make sure you always, whenever you take your child to the clinic, that the Road to Health booklet is with you. And therefore, then the mothers also spoke about, finding these booklets an important resource, that they read it back to back, that they wanted to read it back to back. Of course, there's a potential for response bias in these qualitative interviews because there's so much stigma around these girls being irresponsible mothers, that during our qualitative interviews, it might be that adolescent girls may have portrayed what they would have the intention of doing rather than what they're actually doing. But nonetheless, the intention was really there, and they relied on both the nurses as well as these Road to Health booklets to access information.
Thank you. I'm reading a question from Fiona Burt, and she says, thanks so much for a very interesting presentation. You talked a little about the health workers' responses to adolescent moms, not always so positive. In many parts of sub-Saharan Africa, this is a real issue in demotivating young moms' clinic attendance with their children. How widespread does this seem to be in South Africa? And then a second question, in relation to health workers, you also referred to the missed opportunity of the routine interactions for broader nurturing care messaging and support. But often they cite lack of time as a reason for not doing this. Did that come up in your research?
I would have loved to speak to nurses who are providing well care in my research, but I unfortunately did not have the opportunity to do so. So in the third study where I'm actually just I can pull up the slide. We did include harsh healthcare worker attitudes at birth, and it was quite a large proportion of the mothers who reported being shouted at birth during while attending the birth facility. I had hypothesized originally that these harsh healthcare worker attitudes might disincentivize retention in the well-care visit schedule. And it was interesting to see that there was no evidence of this association. The way that I clarified that is that when we think about that I could no longer make the assumption that the mother's own experience of healthcare services might influence how she thinks her child should attend healthcare services. So there's almost a distinction. Adolescent girls that we spoke to spoke about attending separate facilities, going to a different place for their own family planning, for their ART refills and things like that. But it almost seemed like there was just this, when it came to their child, the nurses treating you like this was not an important deterrent for them accessing health services, which really speaks to the mother's motivation and wanting to prioritize their children's access. And I'm sorry, I've forgotten the second question now. Sorry, Chantal.
Yeah, we'll come back to it. That was quite loaded, but again, very encouraging because it also shows resilience that in the interest of their children, they're willing to take this abuse because they know the benefits for their child. So again, very encouraging. So we now jumping to data. So this is a question from Colin, and Colin shares with us that the District Health Information System data shows that in the Eastern Cape, immunization coverage at 12 months is about 89%. And that was taken in 2021, 2022. The question is, do general immunization rates decline at 18 months compared to the decline with adolescent mothers and their children? So that is comparing against the national level.
Yeah. So and this is covered in the paper that's published. We did not include children of older mothers in our comparison, so I can only compare estimates at the population level versus our cohort. And we saw that actually the vaccination coverage for DTP3, which is the vaccines that get given up to 14 weeks, our cohort had higher than the I think provincial level in the Eastern Cape, but under one coverage and measles second dose coverage was actually lower than the provincial estimate.
The provincial evidence.
Yeah.
Okay.
So that's
Okay.
just based on comparison. It's not necessarily statistically tested.
Okay. And then we have one more question from Colin. He says, did you find any feedback from adolescent mothers related to vaccine misinformation and possibly around vaccine hesitation? I imagine many of adolescent mothers are on social media, so wondering if this has any effect on their decisions around immunization.
Yeah. So we didn't explore this explicitly in the qualitative interviews, but we did ask, how important do you find these services? Why do you go? Several of the mothers were able to explain that there's a lot of diseases flying around in the communities where they're living, and so it's important for their children to access vaccines. So they portrayed quite good knowledge of vaccine preventable diseases and why children should be vaccinated. During the follow-up surveys that we did in the Hey Baby study, we also asked about vaccine hesitance, and we found very, very, very low. It's like I think less than 3% hesitation for the two items that we included about this. So I would say in our cohort, at least what the girls were telling us, were that they seemed quite confident about vaccines.
This is fantastic news.
Yeah, it's
Yes.
it's interesting because I think something that so Glaucoma did the qualitative interviews, and the way that she interpreted that was that because these girls are living in quite a lot of, just there's a lot of poverty and there's a lot of hardship. Here's a service that you can go to where a nurse will see you and you'll get free services. And yeah, Glaucoma sort of interpreted from this that there was almost this not wanting to be hesitant or not really questioning whether you should go or having an opinion about how important these services are because there's something that you're receiving for free and therefore you should take advantage of it.
That sounds very logical. Yeah, I can see how that would fit. Thank you so much, Camille. This was an awesome conversation. I think you've opened the doors for more health-related conversations within the ECD space. So this was a opener. So thank you very much. Thank you also to the participants who have come on to participate and share with us on today's topic. I just want to highlight for the next webinar, which is on the 20th of August. The topic will be socio-emotional readiness in grade R and later learning outcomes, and that will be by Dr. Helen Hofmeyer. And we look forward to welcoming you in August for the next webinar. And for today, just to say thank you to Camille and thank you to the team that supported the webinar as well. I'm now closing out. Thank you so much.
Thank you so much.